Hi, I'm Mary Stanley, and I will be the moderator for our panel discussion, which will demonstrate a typical multidisciplinary tumor board for breast cancer. I'm a board-certified surgeon and faculty of the American College of Surgeons who specializes in breast cancer surgery and other breast disorders. I'm pleased to welcome my colleagues on this panel to present how our specialties perspectives work together in weekly breast tumor board meetings to ensure the best treatment possible for each breast cancer patient. Dr. Agnes Balla is an assistant professor in the Department of Pathology and Laboratory Medicine at UVM's Larner College of Medicine. She specializes in breast pathology, genitourinary pathology, and surgical pathology. Dr. Puyao Lee is a radiation oncologist in the University of Vermont Medical Center and an assistant professor at the Larner College of Medicine at the University of Vermont. Dr. Erin Tsai is a diagnostic radiologist at the UVM Medical Center with clinical interests in breast cancer, breast imaging and intervention, as well as gynecologic cancer imaging. Dr. Tsai is a member of the UVM Cancer Center. Dr. Marie Wood is the director of the Familial Cancer Program at the UVM Medical Center, a professor at the Larner College of Medicine at the University of Vermont, and the Associate Director for Cancer Control and Population Health Science Program at the UVM Cancer Center. She's the founder and principal investigator of the High Risk Breast Program, which was established in 2003 as a clinical program with a research focus on women with a moderate to high risk for developing breast cancer. Please use the Q&A feature to submit your questions at any time during the presentations, and we will answer as many as we can at the end of the discussion. Without further ado, let's begin. In a typical breast tumor board, we present either a newly diagnosed patient or a follow-up after surgery to review surgical pathology. With today's cases, we will present the case, reviewing images and pathology from biopsies and surgery, and then discuss adjuvant or additional therapy such as radiation, anti-estrogen, chemotherapy, immunotherapy treatments. We will present two cases today that we feel demonstrate how varied approaches to cancer treatment can be and why. So our first case is a 58-year-old woman who presented after routine screening mammography with a density in the lower outer aspect of the right breast. She had no symptoms and she had no prior breast problems, no prior biopsies. So she went on to have additional imaging and biopsy. She's otherwise healthy, has no family history of breast cancer, and presented to me after the biopsy. So first we will review her imaging with Dr. Tsai from radiology.
So I'm Dr. Erin Tsai, and I'm one of the breast imagers at the University of Vermont Medical Center in breast imaging. And so here we have our first patient. This is her screening mammogram at the time of diagnosis. This is her mammogram from 1 year prior. So what I want people to appreciate is first, this is the cranial caudal view, and we do two standard views for mammography. And this is one of those views. So if you will, it's looking at the breast from the top down. And what I want you to notice here in this patient's mammogram, the current mammogram, is that there's this oval to rounded density here in the back of the breast, the posterior aspect of the breast, in this area of fat we call the retromammary fat. And I'll show you that here from 1 year prior, there was nothing abnormal in that location at all. So we see this, and when we go on to look at the next view, we'll have more of an idea of what we're going to call this. So here's the next screening view. And again, this is her current, this is her 1 year prior mammogram. This is the medial lateral oblique view, which is the second standard view for mammography when you have screening. And it's looking at the breast from right to left with a slight obliquity, if you will. So what I want to point out here is we have this, again, oval to rounded density in the back of the breast, the posterior aspect of the breast, that wasn't there 1 year prior. So when we look at this in conjunction with the CC view, we can see that it has borders that we can draw a circle around. And so this would be called a mass on her screening mammogram, and we would call her back for this mass to get additional imaging. And when patients have a straightforward mass on their screening mammogram, we usually go right to ultrasound unless we feel that additional mammographic imaging is needed. And in this case, we didn't feel that way. So we went on to ultrasound her breast. And here we have a still image from her breast ultrasound. And I will point out to you that there is this oval shaped mass here in her breast that is dark or hypoechoic relative to normal fat. And that's how we describe our masses. We describe masses in terms of what they look like relative to normal mammary fat. So this is dark compared to the normal fat. So it's hypoechoic or dark. What I'd like to point out to you here is that the margins of this mass, so the shape is oval, the margins are microlobulated, little tiny jagged outward projections, microlobulated to even spiculated, where there are some spicules of this mass that jut out, if you will. And this is located at the 7 o'clock position, 4 centimeters out from the nipple in her right breast. So as Dr. Stanley said, this is in her lower outer quadrant. This is a Doppler ultrasound image, and we use this to see if there's blood flow to this mass. And what I'd like to point out here is that there is some blood flow at the very periphery of this mass. There isn't a lot of internal blood flow to this mass. And in this static image of the same mass, what I'd like to point out is that it's not oriented with the tissue plane. So if it was oriented with the tissue plane, it'd be going kind of like this as I'm drawing a circle with my arrow. But what we're noticing is it's going like this. So it's anti-parallel in its orientation with normal tissue in the breast. And this also outlines the fact that the edges or the margin of the mass are very irregular and jagged. So this is a concerning mass. It's a new mass, and it needs to be biopsied for further evaluation. So this is just a single image taken during the biopsy of this mass. And you see this bright white line going through the mass here. That's our biopsy needle. And when we're done taking the samples of this mass, we leave behind a small marker that is visible both mammographically, it's visible on MRI. It can be visible oftentimes right after placement on ultrasound. And so we place that so that we can know where we sampled mammographically, and it serves as a surgical guide if this mass needs to come out. So here I just have a post-clip mammogram, and what I want you to notice right here is here's the abnormal finding, and you can kind of see the metallic clip there. It's made out of titanium. And here is just a sort of enlarged image of the same view, showing that we were able to get this clip right in the center of her mass. So now I will stop sharing my screen.
Hi, I'm Agnes Balla. I'm going to be showing you the pathology on this case. So when we receive the core biopsy from radiology, we have fresh tissue that we embed and fix. So we fix it in a special fixative called formalin, and then embed the tissue in formalin blocks, and then cut slides and stain them. So I'm showing you the representative microscopic slide from the patient's core biopsy, the right breast 7 o'clock region. So here you can see an invasive ductal adenocarcinoma. The blue cells here are the invasive carcinoma cells, and they're embedded in this background pink, dense fibrous stroma. Her tumor was a nuclear grade 2. We typically grade the nuclei from 1 to 3, with 3 being the worst appearing nuclei and 1 being the smallest and most well differentiated appearing cells. So on every core biopsy, we perform prognostic markers for estrogen receptor and progesterone receptor, and I'm showing you photographs of those here. So we stain the tissue, and we look at the degree and intensity of staining for estrogen receptor and progesterone receptor. So here you can see her tissue stained greater than 90% strongly for ER, and 60%, so some attenuated staining, but still strong staining for PR, progesterone receptor. We also stain every invasive carcinoma for HER2/neu, and this shows you that this stain was negative by immunohistochemistry. We stain these, all of these invasive carcinoma cases, and we grade them from 0 to 3 in terms of intensity of staining. Hers was -0. So this is a representative section from her lumpectomy specimen, so her final surgery specimen. And you can see that she had a solid tumor here with very little tubule formation, high-grade nuclei, and a lot of mitotic activity, which is a surrogate marker for growth and proliferation. This is an image of her biopsy site cavity here with adjacent solid tumor growing right next to it. I've indicated here the margin. So every invasive carcinoma case, we measure the distance of the tumor to the margins so that we can ensure negative margins on final pathology and communicate that back to the surgeons. So every case comes with a final pathology report summary that we put together for our clinical colleagues. And the components that are included are tumor size, the type of tumor, in this case, invasive ductal, the procedure that the patient underwent. And then we give a sense of nuclear pleomorphism, mitotic activity, and differentiation, which we combine together to give a sense of whether the tumor is well differentiated, moderately differentiated, or poorly differentiated. And that could be an indicator of the behavior of that tumor. We also indicate the margin status, as I discussed, the presence or absence of invasion of the tumor into lymphatics or vessels. And then we summarize the lymph node status of every patient. So this is the final pathology report summary on this patient.
So I'm Marie Wood, and I'm a medical oncologist, which means in these situations, I discuss with patients their risk of a systemic recurrence. That means recurrence outside of the breast and regional area. That recurrence risk is driven by size, the differentiation. Agnes told you this was a poorly differentiated tumor. The nodal status, she told you 0 of 2 nodes were positive. And also the prognostic markers. In this particular case, the tumor is estrogen receptor positive, progesterone receptor positive, and HER2 negative. So this is a 58-year-old woman who has a T1 stage 1 lesion, meaning that she does have some risk of recurrence. She's estrogen receptor positive, so we know she benefits from hormonal therapy, but there's another test that we can look at that tells us how much we can rely on hormonal therapy, and that's called the Oncotype Dx Test. We performed that in this particular case, and she had a score of 51, putting her at a high risk of recurrence after hormonal therapy, suggesting to us that we can't just rely on hormonal therapy. And for her, she chose to actually receive chemotherapy in addition to hormonal therapy, which would further reduce her risk of recurrence. So this is all a systemic risk of recurrence. That might seem kind of excessive for a stage 1 tumor. However, this is our chance to prevent a recurrence. If she recurs outside the breast and nodes, it is not curable. It is treatable, but it is not curable. So the other important thing is the sequencing of events after surgery. And we have to decide if we're going to do surgery. If we're not going to do surgery, we move to radiation therapy, and we hold hormonal therapy after radiation therapy.
I'm Puyao Lee. I'm a radiation oncologist, which means I treat breast cancer with radiation. And I often will meet with patients prior to surgery to discuss with Dr. Stanley the local option for treatment. And then oftentimes after the surgery has been completed and we have final pathology, And at that point is when we decide what the treatment will entail. For an early stage breast cancer patient who in this case had a T1CN0 breast cancer with negative margins, the recommendation is generally whole breast irradiation, which is done over 4 weeks every day, Monday through Friday, or potentially 6 weeks. And that timing is dependent on the patient's anatomy. So for patients who are a little bit larger, we sometimes want to give the treatment a little bit more gently. So we do a little bit less radiation each day over 6 weeks as opposed to 4 weeks. The other thing that can be considered for a patient like this, who is over the age of 50 with negative margins and estrogen receptor positive, would be the option to do partial breast irradiation, which is something that's been gaining some popularity over the last just couple of years. There's been a number of clinical trials that have been published that show that that is potentially equally effective as whole breast irradiation. In this case, the patient, I believe, received 4 weeks of radiation to the whole breast, and that entails 3 weeks of radiation to the whole breast and a boost of radiation to the area around the tumor bed, since the tumor has been removed. And that provides both a decrease in the risk of recurrence in the local area, including the breast and the lymph nodes, as well as an improvement in overall survival. And the studies have shown that which is a part of breast conserving treatment, is equivalent in terms of outcome as a mastectomy.
So now we're going to move on to our second case, and she is a 77-year-old woman who was referred to me after she had first noticed a lump in her breast on self-breast examination, and she went on to have diagnostic imaging and biopsy. She unfortunately had a larger mass in her breast with a lot of calcifications, and she also had a suspicious node. Because the mass was really quite large and some of the nature of the tumor on the biopsy, there was a discussion about treating her with chemotherapy up front. Most patients have the option between lumpectomy and mastectomy, and there's really no difference in survival between those two options, but obviously the process of their treatment is very different. This patient presented with a situation where she would have required a mastectomy up front based on the size of her tumor, but because of the nature of the tumor, and we'll talk a little bit about that with the other panelists, but she was a good candidate for treating it up front with chemotherapy, where we were able to shrink the tumor as well as the lymph nodes so that she could have a smaller surgery. So we'll first review the radiology with Dr. Tsai.
So this is our second patient that we're going to discuss today. And again, we are going to start off with a mammogram. In this case, it's not a screening mammogram because the patient is actually presenting with a problem. As Dr. Stanley mentioned, she was feeling a palpable lump. So what I want to point out first is that we put this little marker on the patient before we start imaging them to indicate the basic area where the patient is feeling this lump. So I'll just have you draw attention to our little marker that we have on her right breast. This is her left breast. And what I want to point out here is that there is a large area of increased density or whiteness, if you will. When you compare it with the opposite breast, her left breast, it is asymmetric, and it corresponds with what she's feeling. As Mary said, it's a large area and there are some calcifications here. And so we want to continue to evaluate this breast with further mammography. Before we do that, here's the Mlo view, which again is the second standard view that we get, whether it's a screening or a diagnostic. And I'll point out again, her left breast looks entirely normal. Her right breast, we now can see that she feels a second lump, which is in her axilla. And here we see some abnormal appearing lymph nodes. Here we see some lymph nodes in her opposite axilla, which are normal. And these look very white and very round. And then it's very hard to see her triangle marker, but it's right here, again, corresponding with this large area of increased density that is asymmetric with the contralateral or opposite breast. So we want to move on and evaluate closer the calcifications that we see with this patient. So we do spot magnification compression views. When we do this on this patient, we can get a better feel that this area of increased density is very irregular. There's some suggestion that there might be some masses here as well. We see the triangle marker again, and we see suspicious looking calcifications associated with this asymmetric density. And they're here. And what I like to point out here is that they're linear in shape. And they're also linear in orientation, meaning they're sort of making a line toward the nipple. And here again, oops, let me go back. Here again, I like to point out that the mass is irregular. And at this point, although we think there are masses, we're going to call it a focal asymmetry, meaning that we see it on two views, but we're not definitively certain that there's a mass. This is a still image from a spot 3D mammogram, where you can actually now begin to appreciate that there are masses associated with this. So we're going to go on to evaluate this further with ultrasound. So this is a static ultrasound image, similar to the first patient. What I'd like you to see is that there's a large lobulated mass that does not respect the tissue boundaries. It's going up and down instead of left and right. This is her nipple. So we can see that this process is extending from her nipple, which is the anteriormost aspect, or the front part of the breast, if you will. And it's extending posteriorly or toward the back of her breast. And we're measuring this in this one image at about 5.2 centimeters. This is the ultrasound image of the additional palpable lump this patient was feeling, and this is an abnormal lymph node. Why is it abnormal? Well, we can see here that there's vascularity here. Now, lymph nodes like to have a central hilum, which would normally be located here, and it would look more white, and we would see blood flow going right to the center. However, in this patient, this is an abnormal lymph node because the hilum of her lymph node has been pushed aside. It's no longer centrally located, but instead has been replaced with a lot of cortical thickening, and the cortex is the part of the lymph node that surrounds the hilum. So this is an abnormal lymph node. And again, these things are very suspicious for malignancy. So we would call this a category 5, which is highly suspicious for malignancy. This patient needs a biopsy not only of the large mass that I showed you, but also of the abnormal lymph node. And so again, we have a still image showing the needle going through the mass here. And on this side of the screen, it's going through the abnormal lymph node there. And again, the post-clip mammogram, just to show that there's a clip here, it's somewhat more posteriorly located in this large area of abnormality. And then here's the clip next to the lymph node that we sampled, and you can see a little air right there from the biopsy. So as Mary was discussing earlier, patients may choose breast conservation or mastectomy. And as she mentioned, this was a very large area of involvement of her breast. And so when we have a large area of involvement, if the patient wants to try breast conservation, aside from an upfront mastectomy, they'll receive chemotherapy before the surgery. And when this is the case, we like to get an MRI to get a further understanding of how much of her breast is involved. And then she'll go and she'll get her chemotherapy, and then we'll get a follow-up MRI to evaluate how successful the chemotherapy has been. So this is her MRI, this is her right breast. It's backwards from what I showed you on the mammogram. This is her right breast where the abnormality is located. This is her left breast. You can see this large white area. This is abnormal enhancement in her breast. And we call this a large area of clumped non-mass enhancement, meaning there's not exactly a definitive focal mass, but just a large area of enhancement. And then her left breast at the same location, there's no abnormal enhancement at all. Sorry. So this is her breast after treatment. And we see it's at the same level here. And we can see the pectoralis muscle here and the pectoralis muscle here. So we know we're at approximately the same level. And the enhancement has essentially resolved. And then I will go on to the next image, which is showing the lymph node that we biopsied. It's an abnormal appearing lymph node. It's rim enhancing, and there's not a lot of enhancement here. And that's because that area was full of abnormal cells. And this is just to show you that there's a clip right here, which is bright. And so we know that this is the lymph node that we sampled. Now on this image, what I would like you to appreciate is, again, we're at the same level and we can see the vascular structures in the chest that look exactly the same. We can see the configuration of the pectoralis muscle, which looks exactly the same. And we no longer see this abnormal lymph node. And so again, after her chemotherapy, she has had a good response.
Okay, so this is a representative section of her pre-treatment core needle biopsy from the right breast, 12 o'clock. And here you see an invasive adenocarcinoma ductal type. This tumor is grade 2 to 3, so it's higher nuclear grade than the prior case that we saw. Again, there's no tubule formation and there's a lot of mitotic activity in this tumor. So again, this is a poorly differentiated carcinoma. This is the prognostic profile again of this tumor. So we did ER, PR stains again on the tissue. And in this instance, you can see that they're both negative. Staining for HER2 was also performed. In this instance, the staining pattern was equivocal, meaning it wasn't obviously negative or obviously strongly positive. And in this case, we invoke a second test called in situ hybridization. It's just a second test that we can do in these equivocal cases. And in this instance, HER2 was non-amplified, so negative. This is an example or a representative slide of the core needle biopsy from her axillary lymph node. And the tumor is largely necrotic in the lymph node, but I'm pointing out here with my arrow that there's small volume of tumor cells that are present in the lymph node. So it was in fact positive for metastatic carcinoma, again, pre-treatment. So she underwent surgery and we received her lumpectomy specimen in the laboratory. And we always start by examining the lumpectomy very carefully in all cases, but very important to look at these in neoadjuvant cases and extensively sample the tumor bed. In this case, we didn't identify any obvious tumor grossly when examining the tissue. So we did extensive sampling and put in a lot of tissue sections. I'm showing you a representative section of the biopsy site, which is critical to identify in every case, just because this is usually where tumor resides if there's any left. In this case, there was no evidence of residual carcinoma. It's also absolute to identify the lymph node that was clipped and that was positive pre-treatment so that we can ensure that that lymph node has no residual carcinoma. In this case, you can see this pink area sort of hyalinization that surrounds these blue that appear to be blue balls. Those are actually all lymphoid tissue. And so this lymph node was negative for carcinoma after treatment. She did have small residual focus of ductal carcinoma in situ, which is carcinoma that's just confined to the ducts, but not invading. And she had very small foci of residual cancer within her lymphatics. as you can see here. But again, no invasive carcinoma left in the breast tissue. So this is a final report summarizing the findings in her lumpectomy specimen. She is a YPTIS DCIS, meaning Y means treated, pre-treated with neoadjuvant, and she only has residual DCIS. She's YPN0, meaning she has no residual carcinoma in her lymph nodes. Her margins were clearly negative for invasive carcinoma, as there was none left, and her DCIS margin was also negative. There was treatment effect definitely in the breast tissue, and there was definitely treatment effect in the lymph nodes as well. So on final pathology, she had 0 of 5 lymph nodes positive.
So this is a case of a 70-something-year-old woman who has a very large cancer and it's node positive. The neoadjuvant approach has a lot of risks and benefits, and this really needs to be thoughtfully discussed with each patient. In this particular case, Mary can't do breast conserving surgery, and that's something that the patient wants. And it also helps the surgeon do a better surgery to do chemotherapy up front. So it's fairly standard these days for women who have triple negative, as we saw in this case, ER negative, PR negative, and HER2 negative cancers. It's also very standard in HER2 positive cancers. And that's because when we do neoadjuvant chemotherapy, we have a very high likelihood of helping the surgeon have an easier time doing breast conservation. We also get important prognostic information from that. So when we eradicate the tumor, as we did here, and see nothing but maybe some DCIS, we know that patient has an exceedingly great prognosis. As Dr. Stanley said, it doesn't matter whether we do the chemotherapy before surgery or after surgery, the survival is the same, but the prognostic information that we get is very, very helpful and helps us plan the next step. Chemotherapy is not without risks, and the older you are, or the more medical issues you have, the more dangerous chemotherapy can be. Long-term effects of chemotherapy, depending upon the agents you choose, can include nerve damage, can include heart damage, can include risk for infection, or sometimes long-term risk for leukemia. So we always have to weigh the risk and benefits. It's not uncommon that in triple negative cancers and HER2 positive cancers, especially those are larger, the benefits of achieving a complete pathologic remission, as we saw here, really outweigh some of the consequences. But it is a choice that every woman has.
So the response to the neoadjuvant chemotherapy is assessed after the surgery, as we saw for this patient. And that very much determines what additional treatments, what we call adjuvant treatments, come after surgery. And in this case, the patient had an exceptionally good response to chemotherapy. It was what we call pretty much a complete pathologic response, which is certainly not the case for every patient. But when what does happen, we know that that predicts a better prognosis, and also potentially allows us to decrease additional treatments and adjust treatments that come after. If there were an incomplete response, we often try to give a little bit more treatment because we know that this tumor didn't respond well to the treatments that have been done so far, and we want to give additional things to reduce the risk of the cancer coming back and improve the chance of cure, including radiation and including additional potentially systemic treatments, whether that's additional chemotherapy or additional hormone therapy. For patients who have initial staging, that is stage 3, like this patient, so a patient who had a larger tumor and positive lymph nodes, or who had extensive nodal involvement, I do still recommend radiation after even a complete pathologic response, because there is evidence that radiation reduces the risk of recurrence, because there's still a small risk of recurrence, and potentially even improves the chance of survival. So for this patient, I did recommend that she have radiation to both the breast and the lymph nodes, including all of the lymph nodes that are at risk, which are in the armpit, around the clavicle, and in the middle of the chest, the nodes that we call the internal mammary lymph nodes. And that is kind of the standard comprehensive nodes that we treat. In patients who have lower stage cancers, so this patient did not fit those criteria, but who have smaller tumors in the breast, or who have had fewer lymph nodes or no lymph nodes involved, if they do have a great response like this, sometimes we omit radiation, or we think about treating fewer of the lymph nodes than we did in this case. I think the other thing that is being studied is in patients who have a great response, even with higher stage cancer, there may be not that great of a benefit to doing the radiation. So there are clinical trials that are currently still undergoing evaluation that are going to show us in the next couple of years whether or not we need to do radiation for everyone, even when they have a great response like this. But this patient did ultimately get the standard radiation, which we would have done whether or not she had the chemotherapy response that she did.
So that completes our presentation of these two different breast cancer cases and how we all interact to work with each other to take care of the patient. We welcome your questions. If you use the Q&A feature on this webinar, we will answer those as best we can. Thanks very much for joining us.